Hello, my name is Todd Hoopman. I'm a pulmonary critical care physician in Coeur d'Alene, Idaho, practicing at a community hospital named Kootenai Health. And during this webinar, I'd like to discuss the recently released and published Veritas randomized controlled trial that was a non-inferiority study comparing CT-guided biopsy to fluoroscopic navigation for electronavigational bronchoscopy utilizing the ILLUMISITE platform. The challenge that has faced physicians and pulmonary physicians in particular is how best to manage a diagnostic strategy surrounding the peripheral pulmonary nodule. And here's a nice example of an upper lobe peripheral 1.6 centimeter nodule. In the past, the gold standard for minimally invasive diagnosis has been CT-guided transthoracic needle biopsy, particularly when focusing on nodules 1.5 centimeters or less. There have been studies that have shown up to 70 to 80% yield rate. Complications of transthoracic needle aspiration have been reported to occur in up to 25% of patients, including pneumothorax requiring chest tube placement, significant hemorrhage, or hospital admission. Navigational bronchoscopy has been shown to have a better safety profile with a marked reduced incidence of pneumothorax, chest tube placement, and significant hemorrhage. And obviously, there are other benefits of navigational bronchoscopy, using that as a navigational bronchoscopy centered approach, including the ability to biopsy multiple nodules in one procedure, as well as complete a staging analysis of the mediastinal and hilar lymph node structures at the same time as the diagnosis of the nodule. The recently completed and published Veritas study has finally put in a head-to-head comparison between transthoracic needle aspiration and navigational bronchoscopy for the diagnosis of these peripheral nodules. This is the first multi-center randomized trial to evaluate these two procedures on a non-inferiority basis. As I mentioned, this is an image from my image files of a patient that I've taken care of, and it's an excellent example of what we're challenged by every day. You see a spiculated peripheral upper lobe nodule in a former smoker. Obviously, this carries a high probability of representing bronchogenic carcinoma, and we need a tissue diagnosis to help aid in the patient's care. This particular image in the past may have provoked the need for a transthoracic needle aspiration, but with the advent of the Veritas trial, it's become clear that navigational bronchoscopy should strongly be considered as the standard of care. I was a participant in the trial, and as a result of the trial, I've been able to approach these exact clinical situations in these patients with greater confidence that a well-designed and comprehensive trial actually supports my recommendations to the patient for electromagnetic navigational bronchoscopy. The patients that I encounter certainly appreciate the knowledge that this question has now been addressed and studied in such a rigorous manner. And so utilizing that data, I'm able to now bring forward to my patients a more advanced standard of care. As mentioned previously, the go-to diagnosis or diagnostic procedure has been CT-guided biopsy. We know that there's an increased rate of complications with CT-guided biopsy, and obviously it's also dependent upon the skill of the performing radiologist. Patient characteristics can certainly play a role in that diagnostic modality as well, including their ability to lay flat on the table, chest wall thickness, and rib and scapular anatomy. CT-guided biopsy is estimated to be performed about 130,000 times every year in the United States, so it is not a procedure that is done infrequently, and utilizing technology to our advantage to try and optimize diagnosis of these nodules has really become the goal of the practice, and actually was one of the main impetus for the decision to move forward with the Veritas trial. Despite CT-guided biopsy being well established, we know that its risk is high. The pneumothorax is obviously the most common, and frankly, by patient standards, the most feared complication. In some studies, it's been reported up to a third of patients require chest tube placement after transthoracic needle aspiration to manage the pneumothorax. And so trying to find a safe alternative to TTNA, while at the same time offering an equivalent opportunity for diagnostic yield, was the goal of the Veritas trial. It's now been published, and the Veritas trial has afforded clinicians an opportunity to discuss with our patients the option of navigational bronchoscopy to allow for a reduced rate of complication, but also allow for us to simultaneously stage the mediastinal nodes and the hilar lymph nodes. The Veritas study utilized the ILLUMISITE fluoroscopic navigation platform by Medtronic. It was designed specifically to help account for CT to body divergence and allow for more accurate diagnosis at the time of the procedure. Now, this study was the first of its kind. It was the first multi-center randomized randomized trial, to evaluate navigational bronchoscopy head-to-head in a non-inferiority standard with CT-guided needle biopsy. The results have been exciting, and as mentioned, they provided myself as a clinician with state-of-the-art evidence to present to my patients recommendations for how to proceed forward with their evaluation and management. The study enrolled 121 patients into the ILLUMISITE arm and 113 patients into the CT-guided biopsy arm. This was in a randomized fashion, and this was across 7 different centers, ranging from academic medical centers to community medical centers, such as where I practice. And the study was designed as a non-inferiority randomized trial, and almost 90% of the nodules that were biopsied were in the outer third of the lung. And this was an important feature for clinicians because traditionally nodules in the outer third of the lung have almost always been recommended for transthoracic needle aspiration. So these particular nodules were specifically targeted as the nodule of interest to be studied. About a third of the patients demonstrated a bronchus sign, and that's obviously been a concern amongst clinicians that perform navigational bronchoscopy, is that the absence of a bronchus sign may preclude the performance of a transthoracic needle aspiration. However, in this study, 2/3 of the patients did not have a bronchus sign and were still enrolled. And then obviously the size of the nodule matters when we're talking about accuracy and diagnostic accuracy. And the median size of the over 230 nodules that were included in this study was 15 millimeters. So we were dealing with small nodules. These were not large and by any means, and certainly created some diagnostic challenges that the study helped to answer in a more complete fashion. And I think that the study parameters and the findings and the inclusion criteria listed here really helped put the study in the state of a real-world application. And as we know from a pulmonology standpoint, the real world doesn't always match with what you see in studies. And so it was nice that difficult nodules were included in this study specifically to try and answer those real-world questions. The patients who underwent CT-guided biopsy had a greater chance of experiencing a pneumothorax, up to 8.8%, required a chest tube. There was a higher percentage of hemorrhage, and so we know that the complication rate is elevated, and you can see that with the ILLUMISITE platform, it was almost a 10-fold difference for patients that required a chest tube, and there was no reported significant hemorrhage at the time of the study. The data around this had been previously hypothesized that we felt there were key advantages to navigational bronchoscopy over CT-guided biopsy, but finally we now have in our hands a randomized trial to help back up and show the non-inferiority status of navigational bronchoscopy. But really more importantly, it also allows me to speak with my patients to that exact effect and tell them that at the same time we diagnose their malignant nodule, we can complete a staging analysis of their mediastinum and their hilum to allow for them an expedited transition into treatment phase, either with surgical resection or SBRT or potentially chemotherapy and radiation therapy. I would certainly say that the release of this study and the inclusion of ourselves in the trial has revolutionized and changed the way myself, but also my partners, meet with our patients and discuss this exact clinical situation. We know that there's substantial costs associated with the complications that can be experienced after a lung biopsy. When we look at a pneumothorax rate of 8.8% and the cost of placement of a chest tube for the patient is significantly different when you compare between electromagnetic navigational bronchoscopy on the ILLUMISITE platform and CT-guided biopsy. For every 100 biopsies performed, there's about $130,000 cost savings across that platform. And then besides just cost savings, there's also discomfort and distress to the patient. And so being able to recommend a procedure for diagnosis that reduces their risk, reduces the cost, and provides them with accuracy has really become what I strive for in my clinical practice. The ILLUMISITE platform was used in this study, and it was utilized for a very specific reason, which it's inherently designed to help compensate for CT to body divergence. It allows for those differences between the planning CT and the actual patient's presentation on the bronchoscopy table to be accounted for. It allows for continuous guidance with regards to tooltip technology. And so really it's the first time that we have had a study that has shown that electromagnetic navigational bronchoscopy with the ILLUMISITE platform is now clinically proven to be safer and demonstrates non-inferiority with regards to diagnostic yield from malignant nodules. And we've utilized the ILLUMISITE platform at our facility for the last 3 years, and we found the correction for CT to body divergence to be really practice changing for what we do. We also find that being able to maintain alignment with that nodule through a series of different biopsy maneuvers is extremely important. When we utilize the target in real time and we're able to realign based upon differences in the patient positioning or inflation of the chest, it really allows us to lock in on that target and feel confident about performing our sampling. We also appreciate the tools that are utilized, whether it's the arc point needle or the triple brush, but allowing for continuous guidance from the tip of that extended working channel becomes important, but then having the tool availability to allow for different manipulations has proven to be inherent for what we do as well. And again, that was one of the reasons that we were included and we're excited to be included in the Veritas study, was to help answer that question of the non-inferiority between transthoracic needle aspiration and electromagnetic navigational bronchoscopy. I think that it's important to know that when I meet with patients, I'm now able to tell them that I can offer you a procedure with equivalent success with a significantly lower rate of complication. And that's really what patients worry most about is, number one, their diagnosis, but number two, what kind of complications may I experience in order to make the diagnosis. And so we find that with a lower complication rate and an equivalency to transthoracic needle aspiration, we are heavily favoring ILLUMISITE technology for electromagnetic navigational bronchoscopy for these patients. We find that it reduces our time to treatment because we're diagnosing and staging all in one procedure. There's no need for a return procedure, and we're able to have the patients seen by our thoracic surgeon and or our radiation oncologist in a much more expedited fashion. So in summary, I really feel that the Veritas trial and the information presented, as well as the rigorous nature of the trial with a randomized study design that specifically targeted nodules in the outer third of the lung that were small in size and over 2/3 of which did not have a bronchus sign, really added power to what we practice on a daily basis. And it gave me the ability to pivot away from a recommendation for CT-guided thoracic biopsy more towards navigational bronchoscopy with the ILLUMISITE platform, and I can do that with confidence. And so, in summary, we find that there's almost a 5-time lower rate of complications with navigational bronchoscopy compared to CT-guided biopsy based upon the study. There's a significant lower cost of ownership for the ILLUMISITE platform relative to robotic lung platforms, and we're now able to make a single episode of care to diagnose a patient's malignancy and stage their mediastinum and their hilum to help expedite their future care plans. Thank you very much for your time.